I think I'm going to try to make it complicated. I'm going to mention the word statistics, and just like that, there's a psychological block that's going to go up. And half of you are going to now tune out because he said the word statistics. But Kurt's point about the sigma metric, this is as complicated as the math actually has to get. And yet you can do a good job in terms of selecting your quality control procedures. I'm going to start with a Hager cartoon. This is one of my favorite. You should trust doctors more. Our first rule is to do no harm. And just think about CLIA QC and the guidance that we're really given. The guidance is 2 levels of QC. That's the basic guidance. And Helga says, it worries me that they need a rule to figure that out. There is nothing in the CLIA guidance about how you interpret those results. You just have to run 2 of them, preferably on a chart that has some limits someplace, but they can be any place you want them to be. As long as you have some rationale for why you would use this SD for setting your control limits. And you can make it so the limits are sufficiently wide that you never, ever see an out-of-control problem. And you are in compliance. And it worries me that laboratories need a rule like that, and it worries me even more that they will follow it. ISO 15189 gives us better guidance on assuring the quality of examination procedures. Performance specifications for each procedure used in an examination. Examination is ISO's terminology for method. Shall relate to intended use. And the laboratory shall design internal quality control procedures that verify the attainment of the intended quality of results. ISO doesn't say run 2 QCs. ISO says design your QC based on the intended use, which is the clinical needs for the test. CLIA's got none of that in it. Run 2 of them, set limits any way you want, you're okay. So this is a real limitation of practices in US laboratories. And at some point, we need to get tuned in to what is necessary to really provide good quality testing results. So how can you accomplish this kind of design or selection of control procedures? Well, it's pretty easy using Six Sigma concepts. The thing that Six Sigma forces you to do is to define how good the test should be. You can't calculate a sigma if you haven't defined an allowable total error. And once you define that and you measure the precision and the bias of your method, you can calculate sigma. Initially, we can get the estimates from the validation experiments we do. Later on, you've got routine QC data. Later on, you've got proficiency testing or EQA data. So you can update your estimates of sigma during the life cycle of your method. And what Six Sigma says is you should have performance that is sufficiently good that the tails of the distribution really all fit within your quality requirement. Now, how do you define this tolerance specification? Well, an easy starting point is the proficiency testing criteria or EQA criteria. All of you participate in a program like that. Your results are graded. What are they graded on? There's some definition of an allowable total error. So that is the starting point. Now, there are other ways to come up with that requirement. There's a lot of guidance on how to use biologic variability to do that. So there are a lot of recommendations in the literature. There are a lot of sources of information.